हो का? मजा घेऊ का? लॅपटॉप घेऊ. हो नाही तर हॅलो. हा गुड मॉर्निंग सर.
इथला वॉल्यूम बंद कर, तिथला चालू ठेव मोबाईलचा.
हॅलो. तुमचा आवाज नाही येते सर.
तू हेडफोन लाव. हेडफोन आहे हेडफोन
हेडफोन
त्याशिवाय ते ऐकायला जाणार. ते तसंच होतं ना, बऱ्याच वेळा स्पीकर हे असतं.
हॅलो. सर आवाज नाही येते सर तुमचा.
तुम्ही अनम्यूट करा म्हणा.
नाही सर आवाज नाही येते.
मला वाटतं तो पण ऑप्शन ठीक आहे आपला गुगल नाही. युट्यूब इज बेस्ट. पण जर हे आता तर मग यांनी कसं ऑप्शन मला युट्यूब त्यांचे तेवढेच होते म्हणून मग ते डिड ओके.
मोबाईल माझा मोबाईल घेऊन तिकडे चैतन्य
सर आपको बैकग्राउंड देना है ना पीछे.
सर्व्हिस म्हणजे मला इथे जेवण पाहिजे.
हॅलो. येस.
सर ऍक्च्युली महाराष्ट्र मेडिकल काउन्सिलची सीएम लिस्ट बघताना तुमच्या कॉलेजचं मला आता दिसलं. तर मी गायनेकोलॉजिस्ट डॉक्टर स्नेहकी तटोकर बसते म्हणतात जॉईन होऊ शकतं का कोणी सीएम?
होतं का मॅडम?
Actually मला माहिती नाही लिंक
बरोबर. आता नाही, पण नंबर होतो मी. या हा 88चा नंबरवर तुम्ही फक्त एक मला मेसेज करून टाका तुमचं नाव आणि रजिस्ट्रेशन नंबर तुमचा.
हो.
आणि एक नंबर पाठवतो त्याच्यावर तुम्ही पेमेंट करून टाका 200 रुपीजचं.
200 हो चालेल मी करते. हा
हो मॅडम, थँक्यू मॅडम.
थँक्यू.
जाऊ दे रे आता लोक
म्हणायचं कशाला.
तो मेसेज लिंकचा त्यांनी तुला कुठून मिळाला नाही का मला? ते बाबा तू झालं का ते?
झालं ना, आपण युट्यूब लाईव्ह वर आहे. बघ ना.
मग करू का त्यांना फॉरवर्ड करायची की लिंक
कोणाला?
लोकांना?
झाली केली ती.
सर सर ही याची पाठवायची का?
लिंक नॉट ओपन.
प्रशांत ते युट्यूबची लिंक
काही नको युट्यूबला.
स्क्रीनशॉट काढायची गरज नाही.
त्याच्यात किती जुळली? आता झुंजींचे अजून पण जे काही ठेवली
असं होतं लाईव्ह.
युट्यूबच 10 ते 15 मिनिटं उशीर. ते
15 मिनिट.
हॅलो. हॅलो.
हॅलो. हा सर.
युट्यूब एक 10-15 सेकंद उशिरा चालतो.
चालेल सर, चालेल.
हा? झालंय लाईव्ह. बाकी काही वाटलं टेक्निकली तर फोन करून द्या.
येस सर.
हो हो चालेल.
इथे बघायचं.
Speaking on.
That's it. I don't have that.
स्टार्ट करना वेट करना है
Wait for a while. Another 2-3 minutes you wait.
यस सर
Correct.
A very good morning to all the delegates. Thank you for taking out time from your busy schedule and joining with us. Myself, Dr. Pakhuri Jain-Shah, welcomes you all to the CME on recent advances in postpartum hemorrhage organized by the Department of Obs and Gynae, ACPM Medical College, Thule. Before I hand over the session, let me give a quick introduction of our organizing chairperson, Dr. Nitin Kulkarni sir, and organizing secretary, Dr. Amol Kurane sir. Dr. Nitin Kulkarni sir is a professor in Department of Obs and Gynae, ACPM Medical College, Thule. Sir is a symbol of excellence and a great visionary and a constant inspiration for all of us who is always in touch with research activities. I would like to introduce our organizing secretary, Dr. Amol Kurane sir, who is assistant professor in the Department of Obs and Gynae, ACPM Medical College, Thule. Sir is well known for his surgical innovations and dedicated patient care. Now I'll hand over the session to Dr. Amol Kurane sir, who will be speaking on basics in postpartum hemorrhage. Over to you, sir.
हे पीपीटी माझं कुठं
Hello. Am I audible to everyone? Hello. Again, I welcome you all the delegates who have taken out time from a busy schedule. Okay. We'll be having a question answer session also by the end of the CME. So all of you can have your doubts ready and we can discuss it with all our eminent professors and assistant professors by the end of the session. Okay, so now I'll hand over the session to Dr. Amol Khurani, sir. Sir will be speaking on basics in postpartum hemorrhage. Over to you, sir.
Good morning, everybody. A warm welcome. And this is very crucial topic for us that postpartum hemorrhage is such an emergency in our OBGYN department. Let us go to the basics and brush up some facts. Although postpartum hemorrhage has declined in frequency as a cause of maternal death, it remains significant cause of maternal morbidity and mortality. Postpartum hemorrhage complication including the ruptured uterus account for 6 to 10.5% of non-absorptive maternal deaths in the United States. In our developing countries like India, the maternal death rate from hemorrhage are even more and they are problematic. Coming to the definition, the postpartum hemorrhage is widely defined as blood loss of more than about 500 ml of delivery of placenta. After delivery of placenta. This definition is problematic because The studies of mean blood loss for vaginal delivery have varied findings, often a result of difference in the measurement techniques or patient populations. Careful investigations on the average blood loss, approximately 500 ml in first 24 hours of vaginal delivery. Now, the Pritchard and colleagues have noted that 7% of the women, uh, 7% of women lost more than 1000 ml of blood after vaginal delivery. The blood loss
Recording in progress.
now this is much more good than the actual definition. Etiology of the PPH, we divide the causes. The etiology is primary and secondary, and we all know the four T's, that is tone, tissue, trauma, and thrombin. The tone is majority in 90% cases, and in these cases, the myometrium is not contracted to cut off the spiral arteries. Tissues means retained placental products or fragments. Trauma means lacerations, episiotomy, the uterine rupture, or inversions. The thrombin causes are like DSC, hemophilia, and von Willebrand factors. The secondary causes are generally endometritis and retained placental tissues, which are delayed in basically after 24 hours bleeding. These are delayed. The risk factor which are there for the postpartum hemorrhage are over distension of the uterus, autonomy of the uterus, multiple pregnancies, polyhydramnias, large for gestational age babies, like that. So we can anticipate these risk factors and accordingly we keep in preparation for the respective treatment. In the labor and delivery, antepartum hemorrhage, those patients with the antepartum hemorrhage, placenta previa, cesarean section, emergency or more common than elective cesarean sections. Then prolonged labor more than 12 hours and preeclampsia, previous PPH, previous history of HELP syndrome. These are risk factors. So what are the clinical presentation of the clinical factors? Are bleeding. Those are continuous bleeding after delivery of placenta, blood slope, pads and beddings. Patient might be in the shock, pallor, collapse, hypotension and tachycardia. These are the typical presentation. We will take slight review or if and every factors. The uterine toning, the majority cause of PPH is uterine toning. Patients are at increased risk of uterine toning include those with the high parity over distension of, as we have already discussed. Laceration at the time of perineum, cervix, vagina, uterus may result in visible or concealed hemorrhage, and careful examination of the birth canal, including both inspection and palpation, is necessary to fill out the cause of hemorrhage. The obstetrician should also be aware of potential of uterine rupture because massive hemorrhage can cause and patient can rapidly deteriorate. The retained products of placenta are very much common and typically large placenta like twins and some VDRL or syphilis. These are typically or preterm labor. There are chances of retained placenta which prohibit the compression of the myometrial spiral arteries. The retained production may cause delayed hemorrhage also because of interfering with the involution of the placenta site, and at the time of delivery, metal surface of placenta should be carefully inspected. Okay, the placenta accretia is very much unknown factor when at the time of after delivery, because many of the times it is diagnosed after delivery of placenta or inability of placenta to deliver. In such cases of many of the times placenta previa is the causative factor, and 64% of times the placenta accreta might be there. Previous history of prior cesarean section, dilatation and curettage, abortion, anterior placenta previa, these are the causes. Now coagulopathy, the thrombin causes, T, last thrombin causes, the immediate hemostasis of the delivery occurs by the uterine compression, myometrial spiral arteries. However, most of the coagulopathies like idiopathic thrombocytopenic purpura, von Willebrand disease may also cause PPH. These are many of times not diagnosed previously. But nowadays, because of the much better maternal care, these coagulopathy are known to the gynecologist previously. That is the importance of our hospital delivery-based care. Uterine inversion is not so common, but when it happens, it causes torrential hemorrhage as well as the vasovagal syncopal shock. Those two causes abruptly suddenly deteriorates the patient, and major complication is directly related to the volume of the blood loss. The uterine inversion can occur spontaneously, but usually associated with the uterine fundal pressure and cord contraction of the delivery of the placenta. Primipara, uterine hypoprotonia, fundal placental implantation is associated with increased risk of uterine inversion, and you should be aware of that. So after with these methods, we can prevent all these causes, and these are the routine treatment we all know available as your undergraduate students or undergraduate course, and but at the postgraduate course, some advances are there, and with these advances, we should able to diagnose, treat, and save the life of the patient according to the scenario. So with this, I will conclude this brushing of our basics, and I will hand over the next sessions to the next speaker. Thank you very much.
Thank you so much, sir, for refreshing our knowledge on basics in postpartum hemorrhage. I request all the delegates to keep your questions ready. We'll be having a question and answer session at the end of the CME. Okay. Now, I would like to again introduce our Professor Dr. Nitin Kulkarni, sir, who is a professor in Department of Obs and Gynae, ACPM Medical College, Dhule. Sir is a symbol of excellence, a great visionary, and a constant inspiration for all of us, who is always in touch with the research activities. Now, I request Dr. Nitin Kulkarni, sir, to discuss his topic, that is the golden 20 minutes for management of postpartum hemorrhage. I think it is something which is a life-saving and most important thing everyone should know, and everyone should refresh our knowledge on this golden 20 minutes for management of postpartum hemorrhage to save the life. Over to you, sir.
Thank you, Dr. Pakhuri. Thank you, Dr. Amol, for giving a proper basic information on PPH. Yeah, it's a bloody business, you can say. Just a few days back, we attended one CME, and that time the consultant said that it's a bloody business. Really, it's a bloody business. And most of the dates are happening. Many mortality and morbidity is much more increased just because of the PPH. Till now, the maximum number of the maternal dates are there just due to the PPH. So that's why we choose this topic, and definitely everyone will be agree that if you diagnose this earlier and if you treat it properly in the earliest time, definitely you can decrease the morbidity as well as mortality of all the women. So basically, what should be done when it is? What should be done when the patient is suffering from the PPH? So we'll see for this that prevention of postpartum hemorrhage and what should be done in the golden 20 minutes. How actually what should be this time the was said that's a golden hour. Yeah, definitely a hour is also important. That first few hours are very important. We'll see for this that prevention of postpartum hemorrhage and what should be done in the earlier in 20 minutes. 20 minutes. And if you actually just pardon yeah, the voice is echoing, so that's why I'm taking just a 1 minute break. Is it okay now? No echoing? Okay, yeah, we'll start. So definitely that golden hour is important, and that too, if you diagnose and treat this properly in early 20 minutes, definitely you can maximally you can reduce that mortality and morbidity. Many studies says that the incidence is much decreased when you actually manage the third stage of labor. It reduces almost by 64%. So how to remember this? So PPH main causes the increase in mortality and morbidity. The three delays are there: the delay in the diagnosis, delay in transfers, and delay in the treatment or management. Three factors are very important: amount of a blood loss, rate of a blood loss, and health status of woman. The interval from the onset of PPH to date is 2 hours. By the time the clinical signs appears, 20% of blood volume is lost. So this can be prevented. And for that, always remember this PPH only. The PPH only give you a clue what to be done. So first P stands for prevention, prediction. Okay. The second P stands for prepare. So you be prepared. And third H, that stands for handle. Okay. So predict, prevent, prepare, and handle. And that says about all PPH. So how to prevent? So for prevention, yeah, definitely the regular ANC should be there. As all the guidelines suggest, WHO guidelines, PICO guidelines, FOXI guidelines, SUG guidelines. According to that, all regular ANC should be done. During this ANC, yeah, definitely you can do a correction of anemia. Keep aside the high-risk cases. So identify those high-risk cases and give a proper treatment for those high-risk cases. Delivery in hospital with facility for emergency obstetric care for those high-risk cases. Otherwise, transport to the nearest such hospital at the earliest. Definitely, there should be availability of local or regional anesthesia. And the most important is active management of third stage of labor. And the fourth stage is also very important, which is an observational stage, which many people actually, even in UGs also, in exam, they forget about this fourth stage. But that is very important because that includes this golden 20 minutes or a golden hour. So prevention of PPH in the labor room. For that, anticipation is very important. So anticipation of PPH in every woman in labor. Keep emergency tray always ready. Antenatal risk factors, definitely you all know that what are the which are the women who are at very high risk for the PPH. So those are preeclampsia. Suppose you are given the episiotomy. In that, if you are not followed the proper medial lateral episiotomy, in spite of that, suppose you are given a lateral episiotomy or you are given a midline episiotomy, definitely the chances of PPH will be much more. A patient who already previously taken pregnancy, definitely there will be the more 50% chances of PPH will be there in the present pregnancy also. So yeah, definitely you should predict in those women that yeah, definitely they can develop a PPH and you have to be very careful. Multiple gestation, yeah, distension of uterus will be more in a multiple gestation. So because of that, the chances of atonic PPH will be definitely more. Previous cesarean section cases, this is a very now increased incidence now of PPH in previous cesarean section cases, because we are seeing that already the incidence of cesarean section is increased. Many factors are there. That's not our today's topic of discussion, that why the incidence of cesarean section is increased nowadays. But definitely, yeah, we have to accept. We have to accept that definitely a cesarean section rate is increased, and because of this increased incidence, now the complications are definitely those are also increased. So whenever the previous cesarean section cases are there, the chances of now the morbidly adherent placenta are there, placenta accreta are there. Sometimes it may become a percreta also. So those cases, in that the scar incidence of scardasis now what is
आवाज येतो आवाज आता की रे
mother getting exhausted, chances of fetus is getting exhausted, yeah, definitely the chances of surgeons is also getting exhausted. So all these factors can lead to the PPH. It is when the prolonged second stage of labor. Same like second stage, the prolonged third stage of labor. If it is more than 30 minutes, yeah, you have to predict that it can be due to the morbidly adherent placenta. Maybe some placental abnormalities are there. And because of that, yeah, that will lead to PPH. Again, suppose you are given a wrong direction episiotomies, that can lead to the traumatic PPH. Arrest of the descent. The descent is there after the 0 station plus 1 station, and after that there is no descent. Yeah, you have to predict that something is wrong. Either the problem maybe there in a cavity, maybe there in an outlet, or maybe there in a rotation of the fetal skull. And because of that, there is some arrest is there. You have to think about the deep transverse arrest things. So yeah, suppose this get missed and the diagnosis is not there and the arrest of descent is there. Those cases, yeah, definitely are the cases which can lead to PPH. Okay. Sometimes maybe because of the patient's general condition is not proper. A few conditions are saying like severe preeclampsia, in that the patient is already developing eclampsia, preeclamptic toxemia there, or some medical disorders are there where the anesthesia, anesthetists have to choose the general anesthesia for the patient's care. In that, definitely because of the general anesthesia, chances of uterus will be there. So be prepared. There also predict that this patient can develop the PPH. So that is also one of the predicting factor. So, and that is a risk factor, intrapartum risk factor, where the PPH chances will be much more. Suppose you are going for the instrumental deliveries in such obstetrical labor cases. Yeah, in that, definitely you have to predict, and almost everyone is predicting that whenever I am going instrumental deliveries, the arrest is already there. The rest of the labor is there, and if that obstetrician is skilled, is well and good, but then also with the skill of obstetrician, also the chances of trauma is much more in the instrumental deliveries. So chances of lacerations of vagina, chances of laceration of cervix, maybe sometimes injury to the uterus also. These are the chances, and definitely that will lead to the postpartum hemorrhage. Mostly that time it will be a traumatic PPH. When the labor is augmented, yeah, the augmented labor, definitely suppose you are requiring the more drugs, more oxytocin, more tocotic drugs, more relaxant drugs like drotin and buscopan or epidocin, and that suppose you're using those drugs frequently and you have to augment the labor again and again, so that can be a risk factor for the PPH. As I told you already, instrumented delivery, definitely the chances of PPH will be more again. So you already antenatally you are predicted where can these patients can develop the PPH. Intrapartum also you are ready that such factors were there in this patient, so that patient may develop the PPH. So what to be available in every place of delivery to deal with such complications. So in this particular cases, you have to be ready with all these instruments. So this crash kit and whole your team should be ready. Your wide bore needle cannulas should be there. Those should be granulas number 16, 18, 20. 20 will not help you that as much that time. So definitely 16 and 18 cannula, those should be ready with you. Bulbs should be ready for the grouping and cross matching. Venesection set should be ready, because not every obstetricians are having a ICU with that, and they cannot be trained for the central venous line. So simple procedure like a venesection, that yeah, definitely you can go for that, and that requires just an infant feeding tube. So and you all are must be trained, and everyone is almost trained for the venesection set, and definitely keep that set ready. At least that will help you. Suppose the this intracat or the cannulas are not helping you, and so you have to go for the venesection. The syringes, roller gauze should be ready. Police catheter should be ready. Drip sets, IV fluids, hemorrhage should be ready. Always check in your labor room that this sterile or hemorrhage, whether those with prolonged expiry date or not. And whenever the expiry date is near, always change those sets. And all these drugs should be checked for their expiry dates. And within the expiry date, all these drugs should be available in your crash kit. And the most important drugs, oxytocin, prostaglandins, those should be available. And nowadays, carbetocin, that is one more added drugs is there. The details of all these. Question answer session will be at the last. Some delegates was having a questions. Sir, will definitely, excuse me, will definitely answer your questions at the last part of this CME. From 12 o'clock to 1 o'clock, or maybe suppose CME gets prolonged up to 12:30. We'll definitely will move on your questions. So shall I go ahead? Vimlesh Kumar, he raised the hand. So, sir, can we go ahead? Are you okay that your query will be solved at the last part? Is it okay? Okay. The third stage of labor is indeed the most unforgiving stage of labor, as in it lurks more unheralded tragedy than in the first two stages of labor. So definitely what I told you, what things should be ready, so that on crash kit, all the drugs should be ready, your oxygen should be ready, oxygen mask should be ready, venesection should be ready, all the medical drugs, and as well as whatever the surgical intervention you require, that should be a standby. Suppose you don't have that facility at your center, so the facility should transfer of that patient to the higher center should be in your reach. Okay, what things be checked again in the checklist? Yeah, you should, where you can call. So the call for help should be ready. So primary obstetrician. Suppose others are performing the deliveries, they should have the ability of the obstetrician there. At least in a chief residence of obstetric should be ready. Anesthetic should be in a reach. Assign the roles to the nursing, all roles should be assigned. Identify and treat the cause. My colleague, Dr. Amol Korane, already told you about the causes of the PPH. And in that, all 4 T's you should remember. So first T is tone. Second T is for tissue. Third T is for trauma. And fourth T is for thrombin. So all T's, don't forget about all these 4 T's. Remember this all 4 T's. Okay. And accordingly, that only you have to identify which T is there. It may be a combination of 2 T's. It may be a 3 T's also. So you should identify those T's and treat the T's in a proper time. You should monitor the vitals for every 2 minutes. 100% oxygenation should be there for the patient. Always remember that the first your treatment should be the fundal massage. Keep continuing this fundal massage till you diagnose and till you properly treating the cause for the PPH. PPH. Yeah, definitely a much amount of IV fluids you should be have with you. The rate will be decided according depending upon the blood loss. Catheterization. Many times, just the full bladder is a cause of atony. So that is a very basic factor, and always check that whether the patient is having with a full bladder. If she is unable to pass the urine, she is unable to evacuate the bladder, remember, always do this urinary catheter, and that will help you to examine the genitals there and to examine where is the trauma, what type of PPH it is there. So urinary catheterization is very important. So you should be ready with the 14 or 16 number of female catheter with you. Okay, 2 wide bores cannula, I already told you about that, and the uterotonic drugs like a pitocin, pithagin, misoprostol, and carbotocin. Assess the magnitude of a blood loss. In that, again, this for assessment of this blood loss, many different methods are there. Just a visual this thing observation, that is one. Many graphics are there. You can then nowadays that V-shaped one plastic drape is many are having, and it is already ready. So you can use that drape, and in that you can directly measure. And the last method is a photography also. With that photography, whenever you are collecting the blood, just you can use the photography method, and you can measure you can assess that magnitude of a blood loss. So consider during the recap, during that time, if the blood loss is much more, it will vary from a grade 1, grade 2, grade 3 to grade 4. Here again, I will tell you one more factor. As I told you about the PPH, 40s, and the next is rule of 30. Okay, in that rule of 30, what you should remember is your blood pressure, systolic blood pressure, should not fall more than 30. Her pulse rate should not increase for more than 30. Her urine output should not be less than more than 30 ml per hour. Okay, so always remember this rule of 30. So whenever it is increasing more than 30, definitely the magnitude of this blood loss is getting increased. So you have to be very careful. So if it is going to the grade 4, then you have to say the start the labs like ABG, CBC, PTI, and fibrinogen levels. Okay, always ready with the blood transfusion. In that, sometimes you may require a FFP, sometimes you may require platelets or just a concentrate. Also, you may require. Assess the EBL. You have to be ready with the Bakri balloon. My colleague Dr. Anand Tambat will tell you about the surgical management. In that, he will explain you about the Bakri balloon also. Then the last is in the checklist is phase 2. After 10 to 15 minutes, if the patient is not getting stabilized, so think of a transfer to the higher center. You may think of tranexamic acid also, which is nowadays getting approval for this as a preventive drug for the PPH. Okay, treat a hypocalcemia, because in the prolonged labor, if suppose the patient is nil by mouth since many times, she's not received the proper fluids, she may go in a hypocalcemia. So always keep in mind about that hypocalcemia, and you have to treat that hypocalcemia in time. Otherwise, whatever the drugs, what are the medications you are giving for the PPH, those medications will not help you if you are not treating the hypocalcemia. Maintain an normothermia also. Almost everyone know about the mechanism of hemostasis, so I don't have to go in a detail about this, about the hemostasis. Only thing is that what you have to remember as per the treatment point of view is tamponade. So that is one of the method. So whenever you think what should be done, whether it's expectant or active management of the third stage labor, so always the answer will be active management of the third stage of labor, because we are discussing on that only, that the golden 20 minutes. So this everyone should know about this active management of third stage of labor, because I already discussed you that it significantly reduces the PPH by almost 60%. Significantly decreases the need for blood transfusion. Need for therapeutic oxytocin by reduced by 80%, that is shown by many studies. And what are the components in active management of third stage of labor? immediate administration of uterotonic drugs. Second is delayed clamping of the cord, controlled contraction, examination of the placenta. So definitely that will give you a clue whether there are some retained products or whether there is any abnormality or whether it was somewhat morbidly added in placenta or some abnormality, other abnormality was there of a placenta. So that time only you will definitely, you can treat that immediately and prevent PPH. Palpation of the uterus to ensure the contractility every 15 minutes for at least 2 hours. Always after delivery of the placenta, start your fundal massage. During that massage, always palpate the uterus, whether it is becoming stony, hard or not. Whenever you will feel that it is remaining soft, always start the other uterotonic drugs. Why oxytocin is preferred for this active management? Oxytocin alone is very effective. Oxytocin does not have the adverse effect profile as those associated with the preparation containing the ergot. Oxytocin more stable when exposed to the heat and light than ergot preparation. Just because of the introduction of the newer drugs, many are saying that the oxytocin is not stable in the heat or room temperature. You have to preserve these drugs. But everyone must have experienced that where they're keeping the oxytocin. Almost 80% practitioners are keeping oxytocin in a labor room, in a crash cart, maybe in a drawer, maybe just a trolley which is aside to your delivery table, right? Very few people are keeping that at 2 degrees to 8 degrees Celsius. So don't think that it's not stable. Oxytocin is definitely more stable when it's exposed to the heat and light than ergot preparation. And it's my opinion. You may refer to that opinion, or you may be different for that opinion, that oxytocin is alone a very magic drug, and definitely it's a very useful drug for PPH. Oxytocin alone can manage many cases of PPH. Oxytocin alone can reduce a blood loss in the labor and as well as in a cesarean section. It can be used in settings where the storage capability is an issue. As I told you that, yeah, there is no requirement for 2 degree to 8 degrees Celsius. When to administer prophylactic oxytocin in active management? So prophylactic oxytocin administered intramuscularly after the delivery of the baby. Doses of oxytocin recommended is 10 international unit intramuscularly or 10 to 20 international unit in 500 ml of crystalloid IV. At cesarean section, 5 international unit intravenous bolus, which is latest guideline for everyone, that 5 international unit intravenous bolus you can give. The incidence of induction of labor is on the rise. So even otherwise, the most women in labor have an IV line. Why not use the convenient oxytocin to prevent a PPH? Definitely, yeah, you should go for the oxytocin. The second drug is a methyl ergometrin. Onset is 3 to 5 minutes intramuscular and 1 minute for IV. And the duration of action is more than or equal to 3 hours when it is given intramuscular and 45 minutes when given IV. A dose is 0.2 milligram. Details will be discussed by my colleague again about this drug. Yeah, definitely. Only one line I will say that more side effects are there with this ergometrin, and it is contraindicated in hypertension and cardiac disease. The other drug is carboprose. Again, this will be detailed discussed by Dr. Mahajani. The next drug is misoprostol. Advantage is it can be given by many routes and can be kept in room temperature up to 27 degrees Celsius. It is very cheap and can be used by the unskilled persons also. Now, I want to show you a video that is very important. So when you don't have any settings with you, you can not manage that patient at your setting, the pH grade is increasing, and now you are becoming helpless. So what that attendant, what that accoucher and what all the staff, what that hospital should be trained with. So everyone, yeah, watch this video carefully, and you can treat your all the staff to be prepared to handle this PPH case and to handle that golden hour and to take a proper decision at every time. So just watch this video. Then I will be back within seconds after this video to discuss few points about this video. This is a case, Jyoti, that is Gravida 1. She is 39 weeks, had a normal labor, delivered a healthy baby. Active management of third stage was performed. Placenta was completely delivered, but she developed a frank excessive PV bleeding after the delivery. So what should be done? So one, remember this video, watch carefully. The one is an instructor and everyone is coordinating very properly. And that should be done in every cases. So you must have watched, everyone must have watched this video, and I have not prepared this video. Actually, this is not from our institute also. This is available in a YouTube. Everyone can go and search on a YouTube and watch this video. Many drill videos are there, and definitely these are very good. So I like this video, and that's why I posted this video in this presentation. And you must have observed that each and every step was very helpful. They properly started with fundal massage. They were predicting that PPH. The patient developed PPH. They properly started with the first step of a fundal massage. That means treatment started. Along with that, the diagnosis was also started. They were trying to diagnose what T is there, what T is present in this case. So with that massage, they they were actively managed that third stage, but they required the extra uterotonic drugs. Then the accoucher started to find out what is the cause. First, she catheterized the patient, and then she observed any trauma is there or not. Even if the patient is not of a atonic PPH, patient is just of a traumatic PPH. Many times it happens that patient is developed a trauma, she bled profusely, and just because of that bleeding, the patient after that is going in atony. So the patient is become a mixed type. But to start with that, it was a trauma, and then after she develops atony. So definitely you have to diagnose that trauma properly. That T is very important. So she started washing that vagina. She explored the cervix, whether the trauma is there or not. And after that, no trauma was there. Then she examined the uterine cavity, whether written products are there or not. So last T was also she diagnosed during that time. And with that, she didn't find out any cause, and she continued for that treatment of atonic uterus. She continued with the massage. She continued with the uterotonics, and with that drugs also, she was helpless. The patient was not just because of an infusion, the systolic blood pressure was up to mark, but the bleeding was continued. So during that time, that teamwork was very properly done. One was communicating with the higher center, and you must have observed for that communication, the numbers, the emergency numbers, those were displayed in the labor room. So you don't need not to search those numbers. Those are displayed in your labor room. Immediately you can call for help from those numbers. So that was also a very good point in that. And the other one attendant, she was communicating with the relatives properly. She explained all the things, and that explanation, that communication is also very important nowadays. So everything was a very properly worked there. It was a proper teamwork. And definitely, if you cannot treat your patient at your level immediately in a proper time, you should refer the patient. And while referring the patient, you should refer that patient to the proper place. During that, your foot end should be elevated with the IV drip continued, maybe with the tocotic drugs. Sometimes from the other hand, you can infuse a hemacin. Blood sample should be sent for grouping and cross-matching beforehand only. A paramedical staff with emergency drugs should be with that patient till she reaches a higher center. A prior information to that place of a referral center should be given, that they should be told about all your records, all your treatment details should be on that referral sheet should be there. What you try to diagnose, what you have done, all the details should be there, and the attendant should be with that patient. So that you should keep in the mind. And again, with that, if that patient is not responding, you have to think of the surgical management. And this our last part of our today's CME is about surgical management and the advances in that surgical management, which will be taken by Dr. Anand Tambat. And our next topic will be the advances in the medical management, which will be taken by Dr. Amod Mahajani. So thank you for the patience sharing. I think everyone must have liked the topic. and you will be ready with your queries, and definitely will be available to solve your queries during the CME and after CME also. Thank you, thank you, thank you everyone.
Dr. Kulkarni sir has very nicely elaborated how to anticipate and be prepared to manage the postpartum hemorrhage. Thank you so much, sir, for highlighting the importance of this golden time in management of postpartum hemorrhage. Now, I would like to introduce Dr. Amod Mahajani, sir, who is Associate Professor in the Department of Obs-Gynae, ACPM Medical College, Thule. He is an outstanding academician, senior consulting gynecologist. Many PG students have been trained under his valuable guidance. Sir will be speaking on advances in medical management in postpartum hemorrhage. Over to you, sir.
Thank you everybody. Thank you, Dr. Pakhuri. Thank you, Dr. Amol, for your wonderful lecture. Thank you, Dr. Nitin. Actually, these all lectures have already informed you about basic as well as little bit of treatment about PPH. And here today, now I'll be trying to manage all the bloody business which was created by Dr. Nitin and Dr. Amol. So here, the advances in medical management, I would like to highlight on it. Actually, the thing is already Dr. Nitin has already treated a little bit, but then I would like to highlight further. So going to a little bit again, basic thing is the third stage of labor, which starts with the delivery of the baby and finishes with the delivery of the placenta. Just to refresh your basic knowledge, I'm just trying to go in a little bit detail. Primary PPH is defined as blood loss more than 500 ml after delivery and more than 1000 ml after cesarean section, which is already theoretically given. It may not be so, but finally it depends upon what is the condition of the patient, depending upon the blood loss. So even this definition of PPH can be handled in other way, that amount of blood loss causing deterioration in the maternal health may also be considered as PPH. Now, here, one thing is the first cause of hemorrhage at the time of delivery is uterine atony. So the thing is, today I'll be talking more about treatment in uterine atony than traumatic. Traumatic will be covered in the next topic. But here, uterine atony will be very important. So I would like to suggest you one thing is that proverb has to be followed, that stitch in time saves 9. And that is very, very important, especially in patients who are having PPH. That's why I would like to recommend that active management is much more important as compared to the expectant management. So the thing is, all the time the doctors should be active in managing the patient. Let it be any patient. Not always that, though you people have and prerequisites about this patient who may have uterine atony, especially over distension like prolonged labor, obstetric labor, and so on, whatever the points which were covered by Dr. Purane, the basic. Here, main thing is you need to try to think each patient can have PPH. And that is the way what I'm trying to highlight over here is administration of the uterotonic drugs. Now, these uterotonic drugs are really a wonder drugs which whoever have found out and further manufactured. These uterotonic drugs have definitely helped us overall in reducing the maternal mortality. Now, if you see maternal mortality rate in India, it is around 113. So overall, earlier it was about 130, which has come down to 113. That is a wonder what these uterotonic drugs have done. So overall, let me try to tell you that definitely uterotonic drugs, let it keep on coming more and more, which will be appreciated and welcomed by all our gynecologists. More amount of drugs, lesser amount of blood loss will definitely help us to treat these patients who are having PPH. So administration of uterotonic drugs widely prevents PPH, significantly decreases blood loss, and therefore it is the main line of treatment in the active management of the third stage of labor. So uterotonic drugs are definitely important and definitely has to be used at a proper time. That's why again and again trying to tell you that give the drug at a proper time, which is definitely going to help you for the further complications. So yeah, now I'd like to just tell about expectant management. What the clinicians do is clinicians wait for the signs of placental suppression and spontaneous placental delivery. In contrast, active management involves early administration of uterotonic drug therapy, massage of uterus, placental delivery by umbilical cord traction. So let me try to tell you that once the baby is out, you start your treatment. Medical line of treatment is very important. It has to be started at a proper time, so that the uterus which is going to become otonic will definitely stop that bleeding, and the patient may not have complications. The idea behind stopping this PPH is always remember that this PPH, even if you try to stop little bit amount of blood loss which is going to be there, further the patient may not have further problem in a later part, in the postnatal period. So overall, next, yeah. Now I'd like to highlight about the drugs used in PPH. Now, the drugs used in PPH, as you all know, the first line drug is oxytocin. The second line is definitely you can use either methyl ergometrin, carbopros, misoprostol, or symptometrin. Oxytocin was previously the first line drug which was commonly being followed earlier in the earlier era, and still it remains one of the important drug, and many of our clinicians or the obstetricians are still using oxytocin as a main line of treatment. Definitely, yes, we are having few more advances in the treatment, and I will be appreciating those newer molecules which are coming again and again, and I feel it should still keep on coming. Definitely. Now, oxytocin, which is used as a first line agent, and the second line agent, you can either associate with oxytocin either methyl ergometrin, carboprostromethamine, misoprostol, or symptometrin. I know symptometrin we don't tend to use, which is definitely a combination of oxytocin and methyl ergometrin. So I'd like to highlight a little bit about mechanism of action of oxytocin. Here, rhythmic contraction of the upper myometrium segment. Okay, anyway, rhythmic contraction of the upper myometrial segments occurs, which the constriction of the spiral arteries and reduces uterine blood flow. Overall, let me try to tell you that mechanism of action of oxytocin is rhythmic contraction of the upper myometrial segment. Overall, there will be a fundal dominance, and let me try to tell you that more amount of upper segment if it contracts, it will try to reduce the amount of blood loss, which is basically from the upper segment. Now, oxytocin, the plasma half-life of oxytocin ranges from 1 to 6 minutes. Patient receiving IV oxytocin have immediate uterine response lasting for about 60 minutes. Patient receiving IM oxytocin achieve uterine response in 3 to 5 minutes. So let me try to tell you this time of giving uterotonic drugs is very, very important, where considering the drugs half-life or the plasma half-life, the onset of action and the duration of action is very, very important. So you try to give it at the right time so that the amount of blood loss will be reduced. Definitely, there is a timing. You should give it at a proper time. See that overall everything goes well. And like if you tend to give it early, sometimes there may be retention of placenta, and also considering all these points, you should always give at a proper time. Now, oxytocin may be given IM or by IV infusion it is already recommended. Try to be safe. Even if the thing is, I have already highlighted in the lower point is, should not be given by IV push. So always remember there are side effects of oxytocin if you try to give it bolus. So let me try to tell you that nowadays, many of our newer advances have come that you may give bolus also, but the thing is always try to dilute it with either 10 ml of the IV fluid and give it slowly. Always see that all these uterotonic drugs, if you give it slowly for a time of about 60 seconds or 1 minute, is definitely trying to help you out. So if you go further, the maximum dose of oxytocin is 40 units. Let me try to tell you that oxytocin has been given up till now in ample amount of ampules. So overall, let me try to tell you, there is a maximum dose of oxytocin, which is said as 40 to even 60 units. Even 60 units, up to 60 units oxytocin can be given. But always remember that if it is not responding, there has to be an adjuvant drug to prevent that PPH. Now here, I've already mentioned that overdose or prolonged use can cause water intoxication, which is one of the side effects of oxytocin, which we all know, especially in patients with preeclampsias or PIH, even in patients with hypoproteinemia, anemia and all. These patients may have little bit problem if at all, if you give so much maximum dose. I know we don't tend to need so much of oxytocin, but still there is a maximum dose of each and every drug. I'll go for the other drug, that is methyl ergometrin. As you all know, everybody is afraid about methyl ergometrin, but previously this was one of the wonder drug which was an associate with oxytocin. Earlier, to prevent PPH, I think oxytocin with methyl ergometrin was commonly given. So like as I have already put in further few slides, which shows that definitely one drug may not be useful. You may have to supplement other drug to prevent the PPH, especially uterine atony. And especially those patients who are already having problem related with the PPH or prerequisite conditions where they show that definitely this patient is likely to have PPH, especially in cases of over distension of uterus and all. So here methyl ergometrin, this is a substrate of cytochrome P450 3A, that is the molecule. It is an ergot alkaloid. Methyl ergometrin stimulates uterine contraction by acting directly on the uterine smooth muscle tissue to increase tone, the rate, and the amplitude of the rhythmic contraction. Let me try to tell you that whatever we have observed, or the clinician up till now who are practicing, the senior people as well as the junior people, whoever are newly coming gynecologists, methyl ergometrin will definitely cause a very good uterine contraction, and overall it is definitely going to stop the blood loss unless until indicate. Like contraindications are definitely there for each and every drug, but especially if you see, if oxytocin earlier which was being used, which has to be supplemented, previously they used to use methyl ergometrin, and methyl ergometrin was definitely causing a cricket ball feel of the uterus. So methyl ergometrin, it is available in 1 ml single dose vial that must be refrigerated. Now here again the point which was highlighted by Dr. Kulkarni, it has to be refrigerated, and that's why the potency of that drug will be helpful. Many times what happens is, we tend to give, but then the patient may not respond. We tend to think, how come this is there? Many times people will say that the batch of the drug is not good. It is not at all like that. The drug which is being prepared, it has to be very nicely, and then only it is being brought in the market. So always remember that refrigeration is always has to be kept, but though it is not being followed by many of us. So methyl ergometrin, if it is refrigerated and then brought and immediately given slow IV or IM, as I have already mentioned further, it will be definitely helpful. So methyl ergometrin is available in oral as well as injectable formulation. Further, for PPH, intramuscular administration is preferred with the onset of action of about 12 to 37 minutes, lasting for 3 to 4 hours. So always remember, whenever a uterotonic drug has to be given, always remember the onset of action and the duration of action has to be kept in our mind. Like if the patient is going to have PPH, You should think that, okay, I will try to give this drug so that her duration will go up to this extent and the chances of PPH will be less. So always remember, whenever you try to decide, now since we have so many drugs, we can definitely decide which drug to be given for which patient. Earlier, there was only oxytocin. They had no other choices. They had to give only that and the same drug. Now here, especially further, many molecules are coming. It is really good for obstetricians. Now, methyl ergometrin IV administration is not recommended due to increased risk of sudden severe hypertension. This is always seen. Many times it has happened that the anesthetist, while doing cesarean section and all, they tend to give it off, and later on the patient may have further raise in blood pressure, may again sometimes complain of a severe headache. That is because of the severe vasospasm which is caused by methyl ergometrin. So methyl ergometrin is that ergot alkaloid which is going to cause this hypertension, which we all know. So that's why here further I have already mentioned that IV methyl ergometrin should be used only in the event of life-saving measures where it is required. If administered IV, it should be given slowly over a period of 60 seconds. Again and again, I am trying to tell you that if any drug has to be given slowly for a period of a minute or so. If you give it for a period of a minute or so, overall the action which is going to come, if you even dilute this methyl ergometrin, it will be definitely helpful. You can dilute this methyl ergometrin in a 10 ml syringe with the IV fluid and give it slowly. It is definitely going to help us. And further, the contraction which is going to be caused by the uterus, overall, many times it happens. So overall, even if you do a cesarean section, while doing a cesarean section, once the baby is out, if the anesthetist gives it slowly, you don't even have to do anything. The placenta comes out on its own. You don't even have to remove it. It will come out on its own. The uterus will contract. The placenta will come out on its own. So overall, it is very important that what time and how you give it. So always, definitely, it is helpful. Going to the other drug, carboprost. Yes, carboprost is definitely a wonder drug which has come after methyl ergometrin as definitely helpful. So here it was some E.J. Carey who found out this molecule in 1967, and later on it was introduced in the market in around 1987 or so. And further, really let me try to tell you that this has become one of the wonder drugs. And carboprost, considering its side effect, but here we'll try to weigh the drugs advantage over disadvantage. So overall, carboprost will definitely help you in overall treatment of PPH, and definitely might have saved many of the life of the mothers by reducing the maternal mortality. So carboprost, it is a methyl analog of naturally occurring prostaglandin F2 alpha, which is a very good molecule where they found out this prostaglandin by from COX2 inhibitors and all, and then they found out this prostaglandin, and later on it came into market. So carboprost is a tromethamine salt of 15-methyl prostaglandin F2 alpha. So it is really a wonderful drug which should be. Now here they have already mentioned that carboprost should not be used for more than 48 hours continuously and is indicated for intramuscular administration only. Many times even intramyometral installation of carboprost has been done, where the uterus has become very flabby, and then you may have to even give intramyometral also. Now I already put it a little bit highlighted that IV administration of carboprost may result in hypertension, vomiting, bronchospasm, or even anaphylaxis. So that's why please don't use carboprost IV. I think there was one case which was reported where IV carboprost was given and the patient has succumbed. So that's why please remember that IV administration of carboprost is not at all recommended. The mechanism of action of carboprost, it improves uterine contractility by increasing the number of oxytocin receptors and causes vasoconstriction. So overall, if you see the mechanism of action of each and everything, especially if you see for carboprost or even oxytocin and all, number of oxytocin receptors are very helpful, and that's why more amount of oxytocin receptors come into picture, the result will be that much better. So going to further that, each 1 ml of carbopros solution will contains 250 micrograms of carbopros, 83 micrograms of tromethamine, 9 milligrams of sodium chloride, and 9.4 milligrams of benzyl alcohol as a preservative. So overall, that is the drug what is being prepared, and it comes in two strengths, 125, 250, which is already being used for especially managing the postpartum hemorrhages. So 250 micrograms intramuscular or even myometrium, as I've already mentioned earlier also, can be repeated every 15 to 90 minutes for a total dose of 2 milligrams. So overall, you can give maximum of 8 injections intramuscularly after every 30 minutes till the uterus contracts completely, and overall there will be stoppage of bleeding. So you can use it considering the especially the points which you have to keep it in mind, especially that I have put it in this slide, is avoid in patients with especially asthma or a significant renal or hepatic or a cardiac disease. Now let me try to tell you the cardiac disease. What they have said is about stage 2, stage 3, stage 4 NIMA-National classification. You try to avoid carbopros because again it goes in favor of dyspnea. So as it is already mentioned earlier that avoid in patient with asthma or a significant renal hepatic or cardiac disease, it will be all depending upon the dyspnea as well as the patient who are having asthma. So NYHA 2, 3, 4, they say don't try to use this carbopros, and then basically you can definitely use it for other to prevent PPH. I'll go for the other molecule, misoprostol. It is again a prostaglandin E1. So since this prostaglandin has been introduced, it has overall found out that PPH has been reduced very markedly. So overall, a synthetic analog of E1 prostaglandin, that is misoprostol, which stimulates uterine smooth muscle contraction. Again, here you can see smooth muscle contraction has been effective for misoprostol as well as methyl ergometrin. So misoprostol is available in 100 micrograms and 200 milligram tablets and should be stored at a room temperature. Here, temperature and storage is also important for each and every drug, considering the potency of each and every drug. So mechanism of action of misoprostol, it causes generalized smooth muscle contraction, and because of which overall the spiral arteries will be constricted and overall it will prevent the blood loss. So primary administration method for PPH management is, earlier they used to use rectally in the dosage of 800 to 1000 milligrams. Although oral or sublingual doses of 600 and 800 milligram may also be used. So misoprostol can be used in either routes. And earlier they used to see that even if the patient is about to deliver, sometimes they used to give sublingual or oral. So it can be used as an adjuvant to the oxytocin. Earlier, like oxytocin was the first primary drug, and later on misoprostol was also being used as a adjuvant to the oxytocin drug. So onset of action is again 9 to 15 minutes, half-life is 20 to 40 minutes, and duration of action is about 3 hours. So here you always remember that how much is the duration of hours, and this duration of hours is always going to help you. Up till now, I have already mentioned about all these drugs. Now we'll go for the advances in the medical management in the PPH. So advances are always there, and I feel you should furthermore advances should keep on coming. Every new molecule should come, which will try to prevent PPH as well as maternal mortality and all. Like if I try to tell you that it is about 25% patients, like the mortality rate of maternal mortality rate, here PPH will contribute to about 25% of whatever the mortality rate is. That's why here it is always important that definitely a newer molecule should come and it should try to arrest that PPH, especially if you consider uterine atony. So here a newer molecule has come in market. What you can tell you is carbetocin. Carbetocin is basically a modification made to the oxytocin structure. Here they have substituted hydrogen atom, substituted the carbon atom and the methyl group. So overall, if you see, newer drug definitely helpful. We want to have this newer drugs which will be more helpful in arresting the blood loss. So if you see, it is a long-acting synthetic octapeptide analog of oxytocin. Again, let me try to tell you, it is an octapeptide analog of, again, oxytocin with agonist properties. Means oxytocin, whatever it was being, the mechanism of action was there, the carbetocin is going to follow the same, but for a longer time. So it is sort of an agonist. It is pharmacologically designed for more sustained contractility effect as compared to oxytocin. So overall, if you see, carbetocin will be now coming in the market with more of an advantage, and it will be definitely helpful, I suppose, though further trials are being done. And I think many of us have been started using this carbetocin molecule also. So mechanism of action, if you see, first mechanism, now let me try to highlight about this mechanism. It is very, very important. After binding to oxytocin receptor, it activates phospholipase C. In turn, it activates membrane calcium channels, allowing its passage into the intracellular space. So always remember this mechanism of action for carbetocin are two mechanisms. Second mechanism is activates inositol triphosphate, that is in turn acts on the sarcoplasmic reticulum, releasing calcium. Now let me try to tell you, if you try to see this both the mechanism of action, below I have highlighted that both pathways, cells will have sufficient calcium to trigger a longer and a sustained contraction. That's why it is very important that the calcium channels are the has to be more in the mechanism of action of any of the drug, which will try to prolong its action and the duration will be increased. So as it is given here, carbetocin, definitely it has two mechanism of action, and because of this two mechanism of action, I think it is a drug of choice in today's scenario. Now duration of action is about 4 to 7 times that of the oxytocin due to increased plasma half-life and as that of the oxytocin receptors in the uterus. Again, the mechanism of action comes somewhere into picture as number of oxytocin receptors. Earlier also, as I told you, that oxytocin always has more amount of oxytocin receptors. The same way the carbetocin will also act on more amount of oxytocin receptors. So oxytocin receptors, as you know, it will be more at term pregnancy as compared to preterm. But then definitely, yes, oxytocin receptors are going to help us, as you have already seen in even prostaglandin, especially prostadine, where they have found out that again oxytocin receptors are being activated, and that is going to help us. Now the onset of action is about 2 minutes by IV or IM. Now here the onset is same in IV as well as IM, which is not seen in the other molecules. Like if you give it the methyl ergometrin, the action is varying according to IM or IV. But here in carbetocin, the action remains same. It is 2 minutes by IV or IM administration. Half-life is about 40 minutes. And yes, half-life is very nice, 40 minutes. So IV injection, it produces sustained uterine contraction within 2 minutes. It is very good molecule. And I think within 2 minutes, if it is lasting for 6 minutes, followed by rhythmic contraction for about 60 minutes. And this is one important mechanism of carbetocin. What is being shown here is 60 minutes rhythmic contraction will definitely try to contract the uterus completely, and this rhythmic contraction is definitely going to stop the blood loss. Intramuscular injection produces sustained uterine contraction within 11 minutes, lasting for about 120 minutes. Now here you can see, they have seen that you can give it intramuscular, the action will start by 2, but then further it may last for about 120 minutes. So overall, definitely intramuscular will be helpful. But then here you have to decide which route to be followed. Depending upon the patient and the prerequisite condition of the patient, you can decide, okay, you can give IV or IM. As rightly told by Dr. Kulkarni, that the timing of the mode is very important, that when you will advise the anesthetist or even the staff to administer the drug. Now, sometimes it has happened that the patient, the baby has delivered, you have already administered it, definitely yes. Or sometimes even in cesarean section, once the baby is out or at the time of taking incision on the uterus also, few people have recommended that you can give it at the time. So it will take about 2 minutes, though you should be fast enough to get the baby out. Now here I will go for the further thing is mode of administration. So what is the mode of administration? As soon as possible after delivery of the infant. Now this is very important. Always remember, they have already mentioned that after delivery of the infant. If you are good enough, fast enough in doing cesarean section, definitely you can give at the time of the incision of the uterus. But otherwise, they have recommended as soon as possible after the delivery of the infant and before the delivery of the placenta. Second point is it should be administered slowly over a period of 1 minute. As I'm trying to tell you again and again, always try to administer any drug slowly for a period of 60 seconds or 1 minute, and intended for single intramuscular administration only. Now, this is the last point is very important. Mode of administration, I have already mentioned that it is intended for single intramuscular administration. Let me try to tell you that further doses of carbetocins are still now not recommended. Now, pharmacokinetics, terminal elimination, half-life is about 30.
तो अभी कैसा करूं? इधर से नहीं तो अभी करूं मैं? वेट करते कनेक्टिंग आ गया. Yeah. Okay. There was a little bit failure of electricity. Anyway, I'll continue further. Now, there are contraindication of carbetocin, and this contraindication has to be known by each and everybody. Here, like pregnancy and labor before delivery of the infant is contraindicated. Must not be used for induction of labor.
Recording in progress.
Yeah, now I hope I am audible for you people. So I'll go further for carbetocin. Contraindication of carbetocin, pregnancy and labor before delivery of infant. Yes, definitely. Must not be used for induction of labor. This is very important point. Induction of labor, you should not be using carbetocin. Renal and hepatic disorders, definitely don't use. Serious cardiovascular disorders. Now this is again will be a point to be discussed about serious cardiovascular disorders. I think trials will definitely help us to find out that can we use carbetocin especially in cardiac disease patient with pregnancy. Again, epilepsy, I think this will be all relative contraindication and definitely patient hypersensitive to the active substance. So this further trials are needed to find out that cardiovascular disease, epilepsy and hypersensitivity patients, whether it will be helpful or not. Now, this is whatever the chart what I'm trying to explain till now, where you have oxytocin, carbetocin, methylergometrin, syntometrin, then misoprostol and carbopros. So overall, a complete chart is being mentioned over here. You can take a photo out of it where everything is being given like dose and route, onset of action, duration of action, side effects, and contraindication. Now, if you go highlight about carbetocin, if you see the side effects, the nausea, vomiting, abdominal pain, hypotension, headaches are definitely there with carbetocin. Though it may not be seen sometimes with carbetocin, but other drugs are definitely going to have more side effects and even contraindication as compared to carbetocin. So, instead of informing you of informing you more about carbetocin, I would like to compare this carbetocin with oxytocin. I have compared a few drugs with carbetocin, where you can definitely find out which drug will be better for your choice. Now, if you see the vaginal delivery, oxytocin, carbetocin, estimated blood loss they have given more amount of like more than or equal to 500 ml in oxytocin group as well as carbetocin group. Postpartum hematocrit. This is very important. Postpartum hematocrit is not been considered anywhere in any of the patients, like considering the treatment of PPH. Here, postpartum hematocrit is very important, especially for a postnatal stay of the patient, which will be helpful further. So here you can see in vaginal delivery, if you compare carbetocin with oxytocin, definitely carbetocin has a upper hand. In emergency cesarean operation, they have found out that the need for additional uterotonic was there in 28% in carbetocin group and 51% in oxytocin group. That means definitely carbetocin again has an upper hand as compared to oxytocin. Now here further I have compared carbetocin to misoprostol. Now studies are being going on, and with minimal studies which have been there, they have found out that the study outcomes showed that the blood loss, the third stage of labor with carbetocin was definitely less as compared to misoprostol. So if you see, misoprostol may be used but may not be used by many of them. But few people, they say that earlier what we used to do, we used to give oxytocin and then sublingual misoprostol we used to go, which had a very good result. So definitely the thesis has to be conducted over here about oxytocin, misoprostol, carbetocin, misoprostol. You have many theses coming now. So overall, the other point what I would like to highlight is systolic blood pressure, diastolic blood pressure was more in misoprostol group as that compared to carbetocin. So definitely let me try to tell you that carbetocin has definitely an upper hand in everywhere. Again, carbetocin with misoprostol, if you see the side effects of misoprostol, as I've already highlighted over here, you have facial flushing, headache, diarrhea, shivering, fever, I think which are always seen with misoprostol, which is not at all seen with carbetocin. So again, here also carbetocin definitely has an upper hand. Now again, carbetocin with carboprost, actually there is no published literature here regarding the efficacy comparison between carbetocin and carboprost. But let me try to tell you that again, carbetocin will be having an upper hand. If you see carboprost, definitely it will be having more action on the smooth muscle, and that's why you definitely have loose motions and vomiting for every patient, especially when you give intramuscular carboprost. So again, carbetocin will be having an upper hand. Now here, carbetocin dose related, what I would like to tell you that the dose limiting adverse effects are there with carbetocin. I would like to highlight, up till now I was trying to tell you that carbetocin is much better, definitely yes. But then you have drug related hypotension or hypertension where diastolic blood pressure has gone more than or equal to 120 millimeters of Hg. So carbetocin may sometimes have more diastolic blood pressure. So especially in those patients where, now again this will be dose related. Again they have mentioned that dose limiting adverse effects. So they have found out that actually the studies which were being done about carbetocin, they started with about 40 microgram, then they went on 60 and finally ended up with 100. So whatever literature I have got, in which they have mentioned that up to 40 or 60, the effect was quite adequate and the blood PPH was stopping. But still, finally, they went into further studies where they found out that 100 microgram was the best. And then they decided that it should go with the 100 microgram. Though they have found out that you can give 200 or 300 microgram, but still now they have found out that only 100 microgram as a single dose is been recommended for patients who are likely to have postpartum hemorrhage. So that's why carbetocin they found out and they made it as only 100 microgram. Now further, you have severe abdominal pain with either a heart rate of more than 150 beats per minute or tremors, and last but not the least is a retained placenta. So dose related, again, I am trying to stress upon dose related. It is not a complete adverse effects, whatever you are seeing. Now carbetocin, as you can say about breastfeeding, yes, breastfeeding, there is no significant effect on milk letdown, which have not been reported in their clinical trials, and the small amount is transferred into the colostrum or breast milk after a single injection of carbotocin, which has no harmful effect on the baby. So you can give carbotocin, and that will be definitely helpful. So finally, ending up, I would like to highlight some guidelines for carbotocin. Use of 100 micrograms of carbotocin over 1 minute is recommended. Yes, again. Yeah. Heat stable and non-heat stable formulation are available. I think they have come up with a newer heat stable and non-heat stable formulation. If risk of PPH, carbotocin may be used for vaginal, elective as well as emergency cesarean sections. Carbotocin is a longer acting analog of oxytocin, and its increased duration of action, it eliminates the requirement of further dose, and even I would like to say any adjuvant for it. So finally, I have highlighted one thing is, it may therefore be used as a frontline drug in the management of PPH. And I think now many of us have started using it, and definitely it will be helpful. So I'd like to stop my lecture over here. Thank you. Thanks a lot.
Thank you so much, sir, for such an elaborated discussion in a simple way and throwing light on carbotocin, which is going to be the drug of choice in near future, definitely. Now, I would like to introduce Dr. Anand Tamat, sir, who is Assistant Professor in Department of Obs and Gynae, ACPM Medical College, Thule. He is a stalwart in non-distant vaginal hysterectomy and other vaginal surgeries like TOT, TVT, etc. He has actively participated in many live demonstrations, workshops to share his skill. He is a very calm patient teacher and a surgeon also. Sir will be speaking today on advances in surgical management in postpartum hemorrhage. Over to you, sir.
Thank you, and good morning, everyone. Is my voice loud and clear? You can type in the chat box. I can see there are more than 80 participants right from the beginning. It is almost more than 1.5 hours which you are patiently waiting for. Thank you, Nilambari. So it's okay. And is my video, is there any problem?
It's visible.
Yeah, thank you, Pakhuri. First of all, let me thank Pakhuri madam for a wonderful introduction of mine. Actually, I have not been used to listen to such kind words. Thank you for that, actually. So I can see almost 8 participants, and unfortunately, what I want is no interaction till now. So I guess with the permission of the chair, will I have an interactive session straight away? Will it be okay? Because I guess the question answer sessions are also after these lectures. So why not to start with the same, and if the patient or if the participants have any queries, they can actually raise the hand, interrupt me, and then ask the queries. Because then I would definitely like to have these sessions as interactive. Being interaction, getting these interactive sessions, you get to learn so many things. So I guess it will be okay. Can anybody again type in the chat box? Yeah, thank you, Nilambari, again. I guess you all are here not only to make up with your credit points and try to learn about few things about PPH. I can see so many gynecologists who are also here. So at the outset, let me thank the management of ACPM Medical College, Dr. Mamta Patil Madam, Dean Dr. Vijay Patil Sir, my HOD, OBGY Dr. Alpa Patil Madam, and my Dr. Nitin Kulkarni, Dr. Amol Korane, and Dr. Ahmad Mahazani for arranging such a wonderful webinar on PPH, where actually I am getting to learn so many things. I have been described as a very patient person, probably. Yes, I am a patient listener also, but probably that may not be the case when it comes to surgeries. So thankfully, I have been given this task of letting you know all about advances in surgical management of PPH. So let me share my screen first. Okay, fine. So can you all see my screen? Is my screen visible? It has to be interactive. Come on. Yeah, thank you. Anybody can actually unmute themselves and speak also. I'll be most obliged. Okay. Thank you so much. So here we go. Surgical management of PPH at tertiary center. Till now, you saw the basics of PPH, the types of PPH and the causes of PPH, and what is that golden 20-minute rule where you have to manage everything like a first aid for PPH. And if necessary, then you need to send the patient to a higher center or a tertiary center. And before that, I think Dr. Amod Mahazani had also wonderfully explained about all the medical management. I think it should be available at the grassroots level itself. Fine. So without this much, let me go directly to say something like starting of surgical management. Let us see this slide first. Though pregnancy is the most dangerous journey of mankind, right? Till now, you have seen PPH as a bloody business, and probably all these 3 lectures may have scared you a lot. Okay, but I guess it is not the case, not the same story everywhere. Because unless you are excited to manage a case of obstetrics, you are not going to give justice to the patient. So be excited, be as excited as, like, say, whosoever a player who is playing his compassionate game, who is trying to be, who is trying to competitive. So you must have that competitive spirit to manage this kind of obstetric cases, the sudden PPH cases, whatever comes your way. And once you are excited, probably that brings out the best in you, right? Let me go to this slide. As Dr. Nilesh Kulkarni already told you about recognition and referral, there has to be responsiveness from this referral center, right? So whether you are referring the case or managing case, say in a heart, say in an institute, say maybe in a primary center or a rural hospital, you should be in a position to correctly assess the situation, do a primary care, and then refer if necessary, or else you should be capable enough to manage such cases at your own level, right? So there are plenty of protocols which we need to follow, as we have been already about 4 T's of PPH, like tone, trauma, tissue, and bin. So let me go with, say, advancement in management of hypertonic PPH. You must have seen right now medical management, which is wonderfully being led by Dr. Amod Mahazani sir. Balloon tamponade is you can use at your primary level, maybe in a tertiary, maybe in a primary or secondary center, may not be in a tertiary center. This is like a life-saving procedure. You must have heard about Bakri balloon. So it's a 2-way catheter, which is temporary control of PPH, feasible in a scenario of atonic PPH following a vaginal delivery, which is unresponsive to medical management. And before an intervention radiologist, see, I am letting you few words here, which are advances in surgical management as well as medical management, which a PPH case probably is being managed or tackled in such a way. So radiological interventions are also there, surgical interventions are also there, but Bakri balloon is a thing which is very simple, cheap, easy to use, and is having an effective measure. So balloon is totally snugly fits in the uterus. It has to pass way beyond the cervical canal and then the balloon is inflated by about say 500 ml. It is better to do everything under sonographic guidance, yes.
No problem.
And the success is just by declining loss of blood from cervix, and that seems to greenish fold. So for these, probably I must tell you that you must be absolutely sure that the patient is having atonic PPH and nothing like retained placenta or adherent placenta or bits of placenta or any tear or trauma has to be there. So if you are absolutely sure that it is only atonic PPH, Bakri balloon would be most helpful. Once placed, Bakri balloon has an tamponade effect for say more than 8 to 48 hours. So it is better while shifting also. Once the balloon is placed and the patient is being shifted, you can minimize further mortality, further morbidity of this patient, and that is best. In the picture, you can see a type of Bakri balloon. There are different parts. This is the end which is put inside the uterine cavity, and from here we actually instill the saline, say more than 500, or the one which snugly fits inside. And as I told you already, it has to be better to be managed under sonography guidance. So this is about Bakri balloon. If anybody has any questions, they can already interrupt me. The next is, in spite of doing all the medical management and all the management related with, say, non-surgical aspects of postpartum hemorrhage, if the patient continues to bleed, what is next? So theoretically, it is said that you must do in a stepwise manner. There is certain fixed protocol to manage a case of PPH. And first and foremost, out of all, prevention is to conserve the uterus. Most of the time, these patients may not get landed themselves in kind of hysterectomy as such, because that is the end of the family, that is the end of the fertility status for the patient, and patient may not like. Most of these patients are quite young. They are still trying to run their family and probably may not like losing their uterus in such scenarios. So your aim should be to conserve the uterus first. So how to go about this? First, a stepwise devascularization procedures. Like once you have tried to open, see, I'm not going into nitty-gritties of the surgical skills. You must prepare your OT. You must have blood transfusion facilities along with fresh frozen plasmas. You must have an obstetric anesthetist along with you. The assistants which are experienced enough to understand the situation and then dealing with all the nitty-gritties of this surgical and all the intricacies of the surgery, whatever you are going to encounter, that is the end of the that is the end of the fertility status for the patient. Most of these patients are young. Yes. Fine. So this stepwise devascularization procedure was first reported from Egypt, and it is effective in controlling PPH in about 80% of the cases. So 80% of the uteri are being saved by doing this step devascularization procedure. You first start with. Can anybody unmute Dr. Rajesh Jain, please? Fine, thank you. So first is you can have a unilateral uterine artery ligation, or you can have bilateral uterine ligation at the upper part of lower uterine segment, or there can be low uterine vessel ligation after mobilization of the bladder. Similarly, the uterine blood supply is also from the ovarian vessels which are coming directly from the aorta. So about 20 to 25% of the blood supply is coming through these ovarian vessels, and it is necessary when you are decided to ligate uterine vessels. It is of course worthwhile to ligate the ovarian vessels also. So you can ligate either unilateral ovarian vessels or bilateral vessels. But I would suggest you actually ligate both bilateral uterine and bilateral ovarian also. How to go about this? So these are the sites. This lower segment.
तुला ब्रेक करायला सांगितलं ब्रेक साठी
Hello.
कधी एक दिवस तेवीस
Well, as the picture suggests, you need to ligate this.
बाकी आहे
One precaution you need to take while ligating the ovarian artery is you need to ligate it at the level of uterines, not at the level of ovarian. So you need to be very close to the uterine aspect of the tubo-ovarian ligament and try to I'm sorry for these voices actually. Fine. So once the uterine artery is ligated, 90% of the blood supply of uterus in pregnancy is from uterine vessels. Ligation of uterine arteries results in a significant reduction in blood flow of the uterus. And this is the schematic representation of how basically you ligate the uterines, taking into the part of uterine musculature. The exact site is probably a little lower, about 22 centimeters lower to the uterine aspect of the One to 2 centimeter lower to the incision of the lower uterine segment. Maybe a wide bore needle, which is probably a 40 mm needle in vitamin number 1 is sufficient. This is how you do it bilaterally. There are few surgeons who are used to do uterine artery ligation through vaginal route also whenever there is vaginal delivery. So you have to open the abdomen and go for this uterine artery ligation. This requires a bit of practice and expertise, but can be managed very well so that again the anesthesia aspect and all other morbidity features will cut down and patient is probably saved without much. Fine. Now comes to B-Lynch sutures. It exerts continuous vertical compression of uterine vascular system. I guess you all must all be knowing all this. Vicryl number 2 or monocryl sutures are being used. And this is how it is done. You have to take incision while considering B-Lynch sutures, incision on the lower segment, a bit transverse incision in case of atomic uterus where you are opening for after the vaginal delivery. And see, this is the first entry. The second entry is first entry in the lower edge, second entry on the upper edge, and then encircle the uterus and come out posteriorly at the level of the incision and simultaneously go posteriorly 0.4 and then come out anteriorly at the level of incision. So this number 5 is the entry port and number 6 is the exit of this needle, and then you ligate it. This is posterior aspect from where this kind of threads are seen, and then you need to ligate. What this actually does is basically compresses, and assistance is required while you are putting these link sutures. He needs to compress bimanually the uterus, continue to compress it, and then a surgeon put these stitches, billing sutures. There is certain modification also available in literature. Anybody who is used to do it or anybody who thinks that this is more better than whatever B-Lynch is, they can go ahead. This is Hemant type of suturing, a kind of squarish knot with a broad thread which is used. You may use a marceline tape for that also. The thing is, it needs to be removed afterwards. In B-Lynch, basically you are taking a delayed absorber suture material, so you will not open that again. But mind you, doing these B-link sutures, it has its own complications. There are cases where it is reported that necrosis of the uterus occurs, and ultimately such patients may land in hysterectomies after a few days, or maybe immediately because of the necrosis and gangrene and everything. I have seen such cases. So be careful about advocating this. If you are basically expert and if you basically like these procedures, you are having confidence in such kind of procedures, then you can go ahead. Again, in literature, you see these transverse compression sutures for severe postpartum hemorrhages. We usually are not used to doing all these things apart from B-link sutures, or straight away Cho sutures also, like squarish knots, multiple squarish knots. These are knots basically which are put where the sinuses are bleeding inside the uterine cavity. So you need to identify open in the lower segment, identify where actual bleeding is, see whether there are sinuses or not, and take squarish knot on that sinuses and try to occlude those sinuses and minimize the bleeding. So advantage of this Cho suture is it can be taken multiple times on the anterior, posterior, or frontal wall, or even on the lateral wall. You think one thing is absolutely sure, you need to rule out any trauma or any returns of placenta. Now coming to another important aspect of surgical management of a tonic or traumatic PPH is the life. I guess everybody is always excited with this bilateral internal iliac ligation BIAL, and this is a schematic representation where you need to actually ligate. Basically, you need to avoid the posterior division of the internal iliac artery and ligate only anterior division of the internal iliac artery. So picture B, which says you have to ligate it here, that is more important. You need to properly identify. The next picture has very well clearly depicted. There is a very nice dissection. I saw this in literature, and that is why I thought I should let you know. And clearly very well see the actual anterior division and posterior division of the internal iliac artery. And this is the site where you need to ligate the internal iliac artery. How it is done? First of all, you need to identify ureters, you need to identify the common iliac, you need to identify the external iliac, then you need to identify the internal iliac. The ureter is probably medial to it. How to approach? There are two ways by which you can approach. One is direct approach by severing the peritoneum on the pelvic brim and enter directly, or you can always go a bit of safer and more appropriate approach, like in between the round ligament and the infundibulum ligament. You can sever the broad ligament, fold over there, dissect all the loose areolar tissues, and then directly go onto the pelvic brim where you will find all the major vessels. And probably identification of internal iliac artery is just a matter of practice. Once you are used to it, you do. Many times I have seen my colleagues who are practicing this kind of internal iliac ligation scenarios during abdominal hysterectomies or any other procedures, or during routine cesarean sections also. This gives you better idea of how to approach it. But mind you, whenever it comes to a crunch situation, you should have that courage, you should have that conviction that you will be able to do it. I tell you my own scenarios, like when I have passed my post-graduation and I've started my private practice. In very first few cases, there was a case of PPH after a cesarean section, of course, atonic PPH, and I had to do. I had not personally done any intra-iliac ligation before that, but I had observed it for many times by Alma Mater Hospital and Dr. Vivek Joshi being doing all these things. So I knew the steps, and I had the courage and I had the confidence that I will be able to do it. And I finished this bilateral internal ligation within 10 minutes, and the patient was saved. She came back to me again for the second pregnancy, and then we did again a second cesarean section. And so this is how you create the legacy. The patients, once these kind of near miss cases you are able to save, it gives an additional satisfaction. So that is why I always tell my students that you must have that kind of conviction and you must have that purpose of doing this obstetric work, you should be able to do everything related to emergency obstetrics, so that, as Dr. Nitin Kulkarni already told you about those golden 20 minutes, you should be able to recognize the problem and you should have that kind of confidence to tackle the problem then and then only. It saves a lot. It saves a lot of blood losses. It saves patient from having multiple blood transfusion, and ultimately it saves patient from landing itself in DIC. The DIC is the thing which you need to worry about. And so if you manage this kind of cases at a primary level with proper drugs, proper procedures, with adequate amount of efforts put into arrange blood, patient is going to be saved. Take my word for it. This mixture forceps, as you can see, basically comes from lateral to medial aspect. You need to save these iliac vessels, the vein. It is just lying below. You need to cut the sheath on the intra-iliac artery. You need to clear that, make it skeletonized, and then put this mixture from lateral to medial aspect, and then pull the thread. And while you are ligating the thread, ask the assistant to palpate the dorsalis spurious artery or the femoral artery and see the pulsations in those arteries, and then ligate. Continue to feel those pulsations. This is how you take additional precautions, because in a hurry, inadvertently, you may ligate external iliac artery. And if in case you knew it beforehand, it is always better, so that whatever ligation you have, whatever knots you have put, you can just remove those knots also. So these things, these accidents also do happen, but rest assured that these are very exciting things and you can very well able to do it. Just have that conviction, right? As the third indication also tells you about abdominal pregnancy with pelvic implantation of placenta and placenta accreta. These are the very critical cases which you need to tackle. And there lies the advances of surgical management of postpartum hemorrhage. So what are these indications of hysterectomy in postpartum hemorrhages? As you all know, once all the efforts to arrest the bleeding fail, then you need to probably take the decision. But before that, you must have already done this medical management. You must have already done this balloon probably. You must have already done the stepwise devascularization procedures. But still, place in certain peculiar situations. Rather than going for all stepwise devascularization, you need to go for directly hysterectomies. What are such cases? Obviously, cases where there is uterine rupture, and when it is not possible to suture this bleeding ragged edges of this uterus, and probably when uterine artery is already so much damaged that it bleeds at lot many places. That is when you need to take decision immediately and start with hysterectomy. Of course, you need to take those concerns, talk to relatives. Some responsible person should be in continuous contact with the relatives outside the operation theater for the arrangement of blood transfusions. Whenever you are doing this blood transfusion, the typical formula is for 1 bottle of blood to have fresh frozen plasma also. So if you manage this kind of formulas properly, there are fixed protocols. Once you are adherent to these kind of protocols, I think management is very easy. The matter of fact is, after you have been through with all the surgical management, now what else left is the ICU management, and that is why you require a proper support, proper helping ICU intensivist or an in charge who knows about all these obstetrics emergencies, or else you develop ICU and manage yourself. That is the best thing. That is the best thing put forward, I think, for this. As I already told you about this lateral to medial aspect of putting a mixture and just lifting the anterior division of intra-iliac artery and the light. Right. So hysterectomy. So if successful, not only it saves patient's life, but also preserves the functions of uterus, tubes, and ovaries. Should be the procedure of choice for PPH prior to surgical intervention. So here comes the role of uterine artery embolization. There lies the role of intervention radiologist. If your institute is well versed or is so advanced that you have an help of an intervention radiologist, then this is the best thing you can do. Before try to do a laparotomy, you can go in with this emergency intervention radiology and uterine artery embolization, and this procedure in itself saves a lot. Many cases leading themselves to having a multiple morbidity kind of situation, or ultimately maternal mortality. In Dhulia, I guess there are intervention radiologists available. In Nashik also there are intervention radiologists available. And nowadays we are actually used to do lot many uterine artery embolization in cases where you have scenarios like placenta accreta, percreta, or huge kind of fibroids. It may be a case which is inoperable at the moment, or very young patients where conservative surgeries are required. So these are the advances where you nowadays can use this facility of uterine artery embolization. Of course, I have told you about the hysterectomy aspect. Indications are straight away indications for hysterectomy are uterine rupture, secondary to obstructed labor, previous cesarean section. If the rupture is extensive and hemorrhage cannot be contained by suture or ruptured area, then you need to go for the hysterectomy. You can think that this is a case of abruptio placenta leading to coviral uterus and then secondary PPH probably. Where probably you take a decision of doing an hysterectomy. Apart from all the other things related with atonic PPH and uterine rupture and trauma to the uterine vessels and everything, there are certain other traumatic aspects of PPH also, like cervical tear, vaginal tear, or there can be extended episiotomy leading to hematoma, there can be vulval hematomas, there can be perineal lacerations, there can be paraurethral tear or clitoral tear. Of course, uterine rupture, complete or incomplete, and broad ligament hematomas. Recently, we did a case wherein there was no intraperitoneal collection seen, but the tampon which were kept in the vagina were continuously getting soaked. The concerned anesthetist had already sutured the cervical tear twice, but still there was continuous bleeding. So there was a high index of suspicion, though there was no intraperitoneal collection. So we actually went for laparotomy and they did see broad ligament hematoma, which was already having a tamponade effect, and it was even difficult to see the lateral border of uterus and know whether there was any tear or not. So we had to go for an intentional hysterectomy, like an incision of cesarean section lower segment. We opened the lower segment transversely and then put our fingers inside, and then there like the tear where from the lateral left lateral aspect, it was complete tear from top to bottom. And so unfortunately there was no option left, but we went for a hysterectomy in that cases. How to go about hysterectomy? You need to be very fast doing this hysterectomy, because in hysterectomy in itself is going to increase the blood loss. Actually, patient is already quite compromised. Patient is already maybe in a state of shock. You have to revive the patient by giving multiple blood transfusions, and then further added you are doing hysterectomy. So you need to be very fast enough. I'm not telling you about the timings, like say you can do it from 10 minutes or 20 minutes or 30 minutes, but you should be very meticulous. Every drop of blood counts, so you need to be that much precise. The method we follow is like clamp, cut, and drop. Like we don't have to ligate the cut end of the pedicle. You keep that clamp and go on doing till the uterine artery. Once the uterine artery ligation is completed, then you can just slowly and confidently do the pedicle ligations. After that, you remove the specimen. So clamp, cut, and drop is the procedure which you usually follow, and that minimizes quite a lot of time and finishes the hysterectomy in a hurry. This is cervical tear, which you need to recognize and suture. This is the case of uterus. You can see. You can have a screenshot of all this. There are certain protocols which you need to follow. And then there are certain flow charts in how to tackle these uterine rupture cases. Part of it is already being covered in your golden 20 minutes of basics and everything. You need to identify and do it. As I already told you about intentional hysterotomy, similarly, whenever you encounter a case of, say, placenta, accreta, increta, or percreta, in case of previous cesarean section or previous 2 cesarean sections, whenever you expect that there might be severe bladder adhesions, when to identify the bladder margins, you need to also go for an intentional cystotomy. This is a newer advances. So you open the bladder, you follow with your finger palpation the margins of bladder and try to separate. Here, basically, when doing this kind of hysterectomies or surgeries for this placenta, accreta, percreta, where bladder adhesions are there due to previous cesarean sections, you have to be very meticulous with the cauteries, and you need to only go with the sharp dissection, very slow kind of procedure. You know, this is the cases where slow is fast. You need not be in a hurry. You follow meticulously, you go slowly, you see each and everything, and you are going progressively ahead, and then you will be successful in separating the bladder from the uterus and taking out the uterus completely. Many of the times people get basically bored of doing such kind of emergency surgeries, and then they ultimately land up in subtotal hysterectomies. And then, mind you, because of the stump of the cervix and everything, there can be chances of again bleeding, chances of re-laparotomy, and that jeopardize the patient further. So as far as possible, you need to complete the case on one sitting on the OT table. Once the patient is shifted to, say, ICU or a general ward, you must be 100% assured that nothing is going to happen further. You just have to monitor and manage all the post-operative nitty-gritties and make the patient come out of this procedure. So, as possible, meticulous, slow approach, and try to avoid cauteries, any sharp dissections. These are the few surgical steps which you need to follow. Probably written placenta and everything described to you. We were talking a lot about this placenta, accreta, increta, and percreta, and cases of previous cesarean sections. Though percreta is quite rare, 1 in 6,000 to 1 in 40,000 deliveries, but one such case, if you encounter, probably maybe accidental, nothing like it. Maybe jeopardizing the patient or compromising your own surgical skills also, because you get worried. That is why it is called as it is bloody business or a scary business. But I want you all should know that this is also an exciting business. Managing such cases gives you a kind of high satisfaction level, which can't be described in words actually. This is a case of accreta, just diagrammatic representation. Little bit further advancement in the myometrium of placenta in lower uterine segment increta, and a case of placenta percreta. This is a case of placenta percreta, but fortunately it was in the upper uterine segment. You can see this case of placenta previa with ruptured uterus with placenta in situ, a specimen of hysterectomy. There are many changes in the anatomical aspects. You need to be very precise, very meticulous. You need to, as far as possible, avoid the injuries to the surrounding structures. Mainly, you all probably are worried about ureters. Few of the surgeons are used to do uterine stenting whenever they are tackling these cases of say previous cesarean sections with placenta, where they can expect a placenta increta or placenta percreta, to where they expecting further surgical interventions like hysterectomy to avoid ureteric injuries. Probably they are used to doing a ureteric stenting. It may be helpful for those who are naive, those who are new in this kind of emergency situations, but probably in expert hand it may not be that necessary, because we probably able to know the level of bladder, the attachment of bladder, the adhesions of bladder, and course of the ureter properly. But probably these things comes with the clinical opinion. Fine. This is certainly like medical management of placenta increta. We may not go in details. This is about inversion of uterus. I guess nobody talked about this as it. Excuse me. Adherent placenta may be pulled inadvertently during after vaginal delivery, resulting in inversion of uterus. These are the things you might encounter few times in your career. But this, because of vasovagal shock, patient probably presents in a state of shock, and then it becomes very difficult to manage. Probably these are the few further steps of degrees or advancement of uterine inversion. This is first, this is second, this is third, and this is complete inversion of uterus outside the vagina. In abdomen, probably many times for such cases you need to do a laparotomy and then try to pull the inverted part of the uterus through abdominal route. Probably, fortunately, these cases are quite rare, but you may be able to encounter these if you are doing in a kind of remote setup. And this is kind of high index of suspicion. You must have a probably sonography backup, or you have a high index of suspicion and a conviction to tackle these cases then and there. Now here, giving uterine egg bolix is not going to help. Probably you need to do a general anesthesia or uterine relaxant agents so that you will be able to repose the uterus again, which the part which is inverted. These are about medical managements, ICU managements. You can just take a screenshot of this. This is a flow chart. Right. This is the newest thing probably which is coming up. Have you heard about this? Aortic clamping. Does anybody know about this? Can anybody unmute themselves and let me know? Yes. Okay, fine. So actually, these are the cases which I have already told you about, like previous LSCAS with placenta previa, where you are expecting placenta, morbidly adherent placenta like placenta increta or percreta, and there are bladder adhesions also, to minimize this blood loss. Probably I don't want to boast myself, but there was a period in around 2010, 11, 12 when I encountered so many cases of previous LSCS with placenta previa, and then quite a lot, many times a thought came role for classical cesarean sections. In one of the CMEs on postpartum hemorrhage, I guess in around 2012, I asked to a renowned teacher and gynecologist, Dr. Sanjay Gupta sir, the role of classical cesarean section in cases where there is previous LSCS with placenta previa. And then after that, the thought probably picked up, and nowadays a role of classical cesarean section was very well accepted in cases of where there is previous LSCS with placenta previa. The idea is to separate or deliver the baby as fast as possible and then try to tackle and see whether the placenta can be removed, whether it gets separated or not, or whether the patient has to undergo and hysterectomy, obstetric hysterectomy. And there lies the role of aortic clamping. Descending part of the aorta can be clamped. As you all know, probably the cardiac surgeons are used to use such kind of clamps. These are known clamps like DeBakey or Kyle, or there are further clamps like Weber, something. Many researchers have developed such kind of clamps for the benefit of the society, and then you can make use of this. These are the clamps which your cardiac surgeon is very well versed to use it when you are tackling or doing a cardiac surgery or tackling in a case of aortic aneurysms, probably where you want to leave all the aneurysm part. And the same principle can be applied when you are dealing with the case of previous LSCS with placenta perculata, where you can apply this aortic clamp on the descending part of the aorta, which can be kept in situ for say minimum of 50 to 55 minutes without hampering the lower part of the body. Because as you all know, once you clamp the descending aorta, all the blood supply from pelvic down to lower limbs will get cut off. But then you get sufficient time to deal with such cases. And that is how people are now used to use these aortic clamps. Now it is estimated that cases where these aortic clamps have been used, there are less risk of multiple blood transfusions. There is ease of surgery. There is less blood loss during surgery also. So nowadays, aortic clamping is getting precedence over the rest of the things. Whenever you are dealing, say, in accidental cases of say placenta accreta, increta, or whenever you are actually planning a case of when it is known to you beforehand. How to go about this is you can first go with the classical cesarean section, exteriorize the uterus, expose the retroperitoneum, take a nick on the retroperitoneum, expose the descending aorta, and just apply clamp. This all may not take maybe more than 1 or 2 minutes, but this procedure saves patients a lot. So you must all should know that there is such procedure and this is some new thing. There may be some lot of studies which might come up with this, and then probably this is a further life-saving procedure you have. Another aspect of same situation is you can go with intervention radiologist. Now this balloon is probably inserted through the femoral artery into the external, and then common iliac went up to the descending part of the aorta, and a balloon is inflated so that the blood supply is occluded. Same principle, but with minimum intervention. So this is also a new thing which is coming up. So intervention radiology may get precedence henceforth, and you must all should be versed in actually using it or getting the facilities, building the facility, trying to use all these things. Whole aim is to minimize mortality and maternal morbidity accident. So saving life of one, giving birth to a new life is what the essence is. I guess my today's topic was based on this. Thank you so much. I finished. It's exactly 12 o'clock. Hello.
Yes, sir. Yes, sir.
Yeah,
So thank you, Dr. Tambat, sir, for such a nice and detailed, informative lecture and presentation. And really, everyone must have enjoyed and must be thrilled that so much of surgeries we can have, and definitely with the help of all these surgical techniques and some referral center, even if you are not, you cannot perform at your center, you can definitely refer the patient, and at referral center such surgeries can be performed, and so many advances are there like interventional radiology and your intellect ligation, aortic clamp, aortic balloon, uterine artery embolization. So many surgeries you have explained very well, sir. And definitely everyone must be confident now that, yeah, definitely we can treat this PPH and we can help our India to reduce maternal mortality and morbidity. Thank you so much, sir. Thank you.
Thank you. Thanks a lot.
Now,
Thanks for giving me this opportunity.
thank you, sir. Thank you, sir.
Completely stop the picture.
So we'll start with our question answer session. Sir, everyone, every faculty, I will request Dr. Amol, Dr. Amod, Dr. Anand, sir, to be ready with
Yourself.
all be ready, and will whosoever will be raising the hand will unmute that delegate and he can ask the question, he or she can ask the question. So now the session is open for question and answer. You can put your questions in the chat box also. Thank you.
I guess we have made the topic not so toxic. Everybody should be able to gather their thoughts and ask you questions. That would be better, I think.
Yeah. Yes, sir. Yes, sir. If there will be no question, we will have a panel discussion with our all faculties. Yes, Dr. Kiran, you can ask. Yes, Dr. Kiran, you can go ahead.
7 वाजून जातात कधी कधी सायंकाळचे मग 7 वाजले की मग 1 तास अर्धा तास ब्रेक देतात रूम मध्ये आराम करा आणि मग लगेच जेवायला बोलवतात जेवण केलं 8 वाजता जेवण 8:30 9 ला जेवलं तर मग काय झोपत येते दिवसभर ऐकत
I request the host
Yes.
to mute.
Yes, Dr. Shilpa. Yes, Dr. Shilpa, we are unmuting you. You can ask the question.
Sir,
Just wait. Yeah.
Now I'm unmuted. I wanted to ask about the Lumela Glyphen test for PPH. How much is the utility of that test?
Yes.
Point of care machine.
Which test you please?
The company name is Lumela. What it detects is the glycosylated fibronectin levels. So, what would you? Can you please comment on the utility of this machine?
Yes, actually, with this, see, we have all four T's are there. So in that, the last thrombin T. So to detect that factor, whether it's playing a role in the PPH, definitely that machine can be helpful to rule out any coagulopathies are there or not. Whether that patient is going in whether that patient is going in a thrombosis or what, and if we detect that earlier, yeah, definitely we can intervene earlier. We can start with a low molecular weight heparin and we can treat that patient. So definitely it's useful. There is no problem. We can definitely go for that fibronectin levels with the machine.
So is there anyone here who is actually using it, or so that I can understand from them?
Yes, all the participants, you are requested, you can put your comments, whether are you using that or no.
Anyone who's using the Lumela machine. Company is Lumela, what is it called as Glyphen point of care test.
Actually, we have not got this machine up till now, and we are not even familiar with the machine.
But definitely, even if those machines are not available, we have other markers from which we can easily detect, and that is accessible and acceptable for all the consultant as well as the patients. So that's why
Okay, sir.
we are using that. Yeah.
Okay.
It should be affordable also, no? So that's why no one is that much of keen to go for that IFL machine.
Okay. Fine. Thank you so much, sir.
Thank you. Thank you. Any other question? Nilambari Lambedkar. Yes, Dr. Nilambari. I think no more questions are there.
What precautions?
Yeah, it's a good question. The question is from Dr. Swati. If patient is on aspirin and comes in labor, what precautions? Yeah, our routine way is that when the patients previously we used to stop this low molecular weight heparin or aspirin tablets at around 32 weeks only to avoid patent ductus arteriosus. So to avoid those anomalies, we used to stop before only. And after that, the new guidelines were suggesting that you can continue till full term, the patient is becoming full term. And then also sometimes it happens that a patient goes in labor when she is already on aspirin. So only you can go for the APTT timing, that's it. Otherwise, there is no problem. And depending upon the factor, the percentage, you have to give sometimes antidote. Very rarely you have to give an antidote for that. Otherwise, that is not a big problem that patient is continuing the aspirin. You can definitely very well, you can conduct that labor, ma'am. Thank you.
जरा सोनोग्राफी रिपोर्ट मध्ये काही प्रॉब्लेम दिसलेला नाहीये, काहीच त्रास नाहीये. पण तपासणीमध्ये मला असं वाटतंय की तिला ऍसिडिटीचा त्रास झालेला आहे, म्हणून तिथे सतत पोट दुखत असतं. तिखट गरम मसाला आणि चहा पूर्ण बंद करायचा.
Yes, one more question is there about the carbetocin. That is the more half-life is the only advantage of carbetocin. So actually, yeah, that is definitely an advantage of carbetocin, but that is not the only advantage. Longer duration of action, yeah, definitely is one advantage. Second is it's a heat stable. That is the second advantage. And third, you don't have to give a repeated uterotonics. Like suppose you are giving a pitocin, you are given a 10 units, you have to add 10 more units. Suppose you are given a carboprose, you have to give again and again the repeated dosage of prostaglandins in that. But the study says that a single dose of carbetocin is sufficient, that maintains the action, and as the duration of action is much more for carbetocin, so it continues the action. So you will be very, you can easily go home and have a rest properly when you give a carbetocin and you saw that the bleeding is stopped. So you can rely on that. So that the study says. But again, we need to do more research on carbetocins. And definitely, I think this drug is having a magical effect. It will come out after some time. And suppose we will be getting some side effects like maybe renal toxics or hepatotoxic. These side effects are there. So we may have to rethink on that. But at present, definitely it is having advantages over the other uterotonics, that no need of repeated doses.
Nitin sir, yeah.
So the question is for Dr. Tambat, sir. Dr. Tambat, sir.
Yeah, I think there is some comment
Yeah.
regarding Bakri balloon.
There is one question for you. What are the
Yes, yes.
chances of ischemic thrombosis after cross clamping of aorta?
So you have to be quite careful. As I already told you, that we can clamp the aorta for say minimum of 50 to 55 minutes. So during that procedure, if your whole hysterectomy or whatever procedure you are proceeding with gets finished, then it is fine. Otherwise, you can release that aortic clamp. You can set a timer. You can release that clamp for say next 8 to 10 minutes, and then again, if you feel, you can reclamp it. So that doesn't matter. The patient does not have any kind of after effects of such kind of temporary or transient aortic clampings. So that is why I have already told you that these procedures is coming up like that. But then this is like so advanced, and you are actually dealing with a descending part of aorta which takes care of all the lower half of body. You need to have all other measures underway, like you have applied clamp, you noted the timing, you had started with the timer, then keeping an eye on the time you are actually proceeding with your surgery, and if required, you are releasing a bit and then again reclamping it. It is possible. These studies and everything will come up, I'm sure, in near future. But I think these are the advantages. These are definitely advantages to minimize the blood loss and minimize the critical blood transfusions for the patient.
One more question is there. What's the prophylactic dose of tranexamic acid for prevention of PPH during LSCS? So the prophylactic dose is 1 gram in 100 ml of normal saline, just 1 hour prior to surgery. So that is the dose.
In patient with eclampsia followed by yes, definitely yes.
The next question is about on carbetocin for Dr. Amol Mahajani, sir.
Yeah, the question is, can we use carbetocin in patient with eclampsia followed by PPH? Yes, definitely. Yes, I think carbetocin has much upper hand in using as a uterotonic in eclampsia and for PPH. And I think it doesn't increase blood pressure, as I've already mentioned in my presentation. So overall, you can definitely use it, and it definitely has a upper hand. Sure, sure. Military anti-shock trousers.
Actually, on this, we'll like to thank all the delegates who are very patiently here, all the topics, and they raise the questions. So we are glad to hear all the questions from you people, and be connected. We are there again for a few time to answer your questions. So whatever the questions are there, you can ask.
No, that's prophylactic from.
Yeah, one question is there from Dr. Sayogita Taukar. Does prophylactic tranexamic acid increase the chance of post-delivery thromboembolism? No, ma'am. Such studies are not there, and whatever the studies, the Cochrane studies says on the tranexamic acid, it's not having that side effect of thromboembolism. Not yet found. So you can safely use that.
Thank all the delegates for on the topic and they raised the questions. So we are glad to hear all the questions from reconnected. We are there again for few times to answer your questions. So whatever questions are there, you can ask.
Thank you, sir. Such a for such a beautiful compliment. Thank you, sir.
Dr. Sayogita, does prophylactic anhydrous acid increase the chance of post-delivery thromboembolism? No, ma'am. The studies are not there, and whatever the studies, the corporate studies says on the anhydrous acid, it's not having that side effect of thromboembolism. Not yet found. So you can safely use that.
Hello.
Yes, Dr. Ganesh.
Hello.
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 Yes,
sir.
Dr. Jaiswal here.
Yes, Dr. Jaiswal. Yes.
Sir, there are the guidelines we used to read during academic with anterior shoulder of baby delivery. We should give the oxytocin to hurry up the removal of the placenta. But meanwhile, with carbiprost and all that, is there any chance of preterm closure of the internal os so as to cause the retained placenta? Is there any documentation or any guidelines over that?
Yes, definitely. It's a very good question. What we have to remember is what is the difference between oxytocin and other tocolytic drugs. So oxytocin actually acts on the upper segment. Okay. And when you are giving ergot alkaloids, so like methagen, if you are giving, so that what it does, it contracts the upper segment as well as contraction retraction is there of upper segment as well as lower segment. So suppose if you give that methyl ergometrin at the time of anterior delivery of shoulder, definitely that can cause a retained placenta. The placenta will be separated, but it will be retained. So that complication can be there, but definitely not with the oxytocin, not with the carbetocin also. So really speaking, if you give a carbetocin or oxytocin at the time of anterior delivery of shoulder, it will definitely help you and it will decrease the chances of PPH. And that is the point in the golden hour of management of PPH.
Yes, sir. And what is the scenario for prostaglandins and prostaglandin analogs?
Actually, for prostaglandin, yeah, definitely you should wait till for the delivery of fetus.
Okay, yeah.
And I think that is not a first line of treatment for anywhere, not in active management of thirst of labor also. So don't consider prostaglandin as a first line of management. Keep oxytocin only a first line of management, and if you need it, then only go for the other drugs.
No, sir. Actually, what I was talking about, if placenta is not got separated and if we give prostaglandins afterwards, that dose will definitely cause closing of os also.
No.
That will not cause.
No, it will not close. It will not close. It will help to separate the placenta.
Yeah, that is the only intention we are giving in case of retained placenta.
Yeah.
Yeah, sure. Thank you, sir.
What is the scenario about prostaglandins and prostaglandin analogs? Actually, for prostaglandins, they are definitely for the delivery of.
Yes, Dr. Prajakta Kulkarni, she's having some question. There are no more questions. So now I will like to invite Dr. Amol Korane, sir, for the vote of thanks. So I'm handing over to Dr. Amol Korane. Thank you.
after such a good and informative sessions about postpartum hemorrhage, I am very thankful. I am very thankful to all of you. Dr. Vijay Patil sir, who is our principal, I am thanking you, and Dr. Mamta Patil madam, who is our secretary of the ACP Medical College, and I am also thanking Dr. Alka Patil madam, who is a professor and HOD, OBGYN department. I am thank you all of them. Today's speakers, Dr. Nitin Kulkarni sir, professor in OBGYN department, Dr. Amod Mahajani sir, professor in OBGYN department, Dr. Anand Tambat sir, associate professor in OBGYN department. Our speaker who are introduced by Dr. Pakhuri Jain madam, Dr. Akshay, Dr. Sneha madam for active assistant and participation, Dr. Chaitanya, Dr. Prashant, Dr. Hitasvi, our JR for their active support. We are also very much thank you for technical support of Dr. Usman, who is our interns. There are also all interns who have supported us. Dr. Meenal Wankhedkar madam is our central observer of MMC. She is here and she has observed all the process going on. The CME, the webinar is conducted very well. There were all active participation and interactive sessions from all delegates. We are very much thankful for their active support. If there is any flaws in the conducting sessions because of some technical deficiency, so please pardon and bear with us. And very much thank you, all of you, all the staff who have helped us over here. We are very much thank you, all of you. Thank you very much. Have a nice day and good day. We are concluding the session. Hereby I declare that this session is concluded. Thank you very much.